Welcome to the Deep Dive. Today we are tackling a huge topic. We've got a massive collection of sources here, all about neurological assessment, diagnostics, common disorders, just everything.
Everything.
And we're going to turn it into what you absolutely need to know.
Yeah.
So if you're a learner getting ready for a big nursing exam, or honestly, if you just want to really understand the body's master control system, you are in the right place.
Our mission today is pretty critical. We're distilling all of this down to the high-stakes knowledge, what you need to recognize neurologic problems, interpret findings, especially the really subtle ones, and then plan safe, evidence-based care.
Okay.
And as we go through all of this, you'll see three central concepts that drive almost everything. They are mobility, cognition, and sensory perception.
Mobility, cognition, sensory perception. Got it.
Every single thing we discuss today is going to tie back to one of those pillars.
Okay, let's unpack this. I mean, as nurses, our job is hands-on assessment, right? But you can't really predict what's going to happen to a patient without a rock-solid understanding of the basic architecture.
You can't.
If the foundation cracks, the house falls down.
Yeah.
So we have to start with the foundational neuroanatomy and physiology. We're going microscopic first.
Exactly. We have to start with the basic functional unit, which is the neuron. This is the cell that's specialized to transmit impulses, the messages.
Right.
And right away, we need to split them into two functional types. You have your motor neurons, which control muscle movement. That's our mobility pillar right there.
Okay.
And then you have your sensory neurons. That's how we perceive the world, and that handles our sensory perception.
And the structure of that neuron, it really dictates what it does, right?
Yeah.
You have the dendrites, those little branches that are designed to receive the messages. Then the main trunk, the axon, which sends the impulse away from the cell body, and the whole thing ends at the synaptic terminal knob, which is where the chemical handoff happens.
That chemical handoff, the release of neurotransmitters, is just fundamental. You have to know examples like acetylcholine and serotonin. And what's critical, especially for testing, is to understand that a chemical messenger can either enhance an impulse, that's excitation.
The gas pedal.
Exactly, the gas pedal, or it can inhibit it, decrease the action. It can't do both. It's either the gas or the brake.
That makes perfect sense. Okay, so what about speed? The speed of that transmission is everything, and that's where the myelin sheath comes in.
Right, so the myelin sheath is this white, fatty wrapping around a lot of the axons. It's actually the difference between what we call white matter, which is myelinated, and gray matter, which isn't.
And it acts like insulation on a wire, doesn't it?
It's the perfect analogy, but the crucial part is that it has these regular gaps in it called the nodes of Ranvier. So instead of the impulse having to, crawl down the whole axon, it can literally jump from node to node.
Saltatory conduction.
That's the one. And it speeds up the process dramatically.
Which gives us that immediate clinical link. I mean, when that myelin is damaged, like in multiple sclerosis, the impulse just can't travel effectively. It slows down, it sputters.
Or it stops entirely. That demyelination translates directly into problems with mobility and sensations, basically an electrical failure.
Okay, so neurons are the communicators, but they don't work alone. There's this whole support system. The neuroglia or glial cells.
The support crew, absolutely. They provide the scaffolding, the maintenance, the protection, the nutrition, everything.
I always think of them as the unsung heroes.
Yeah.
We've got astrocytes, oligodendrocytes, ependymal cells, microglia listed here. What's the big clinical takeaway about these cells?
It's a bit grim, but it's essential to know. Malignant tumors that come from glial cells, like astrocytomas, are often incredibly aggressive. They have a really poor prognosis because those cells are so fundamental to the whole CNS structure.
And you mentioned astrocytes are part of the blood-brain barrier.
A critical part, yes. They help form those tight junctions. We'll definitely come back to that.
Perfect. So we've covered the micro level. Let's zoom out to the physical protection. The brain and spinal cord. They're not just floating in there. We need to talk about the meninges and the cerebrospinal fluid, or CSF.
The meninges are your three protective layers. So from the outside in, you have the tough, almost leathery dura mater. Tough mother.
Right. Then the spiderweb-like arachnoid layer in the middle. And finally, the really delicate layer that's right on the brain tissue itself, the pia mater.
And knowing the spaces between them is where all the clinical action happens, right? You've got the subdural space between the dura and arachnoid, a common spot for a bleed after a trauma.
Exactly. And then the critically important subarachnoid space. This is where the CSF, which is like the liquid shock absorber for the brain, circulates.
And it's also the space we tap into for a lumbar puncture.
Precisely. And finally, you have the epidural space, which in the spine is where we give anesthesia and analgesia.
Okay, moving on to the brain itself. It's broken down into three main parts. The forebrain, the cerebellum, and the brainstem. The cerebrum, the big part, the cortex, that's your center for all higher functions. We're talking intelligence, creativity, memory, and importantly, control over consciousness and cognition.
And it has two halves, the hemispheres, joined by the corpus callosum so they can talk to each other.
Yep.
For assessment, we have to know the four lobes. I mean, linking a specific deficit to the site of an injury, a stroke, a tumor, that's a core nursing skill.
It is. Let's run through them. We'll start with the biggest, the frontal lobe. This is your personality and action center. It's got the primary motor area, so it's directly controlling mobility.
And speech production too, right? Broca's
Speech center, right in there. Responsible for producing speech. And all those higher level functions are there too. Judgment, reasoning, planning for the future, regulating social behavior.
So if you have a patient with a frontal lobe injury, they might be totally alert, but their personality is completely different. They're impulsive. They can't manage a simple task. That's a cognitive deficit you might miss if you only check orientation.
That's a great point. Next, the parietal lobe. You should think sensation in space. This area interprets sensory input texture, size, shape, and really importantly, three-dimensional or spatial perception.
Proprioception, where your body is in space.
Exactly.
So if a patient can't identify a key in their hand just by feeling it, that's a parietal lobe issue, a problem with sensory perception.
Perfect example. Now, the temporal lobe, this is for hearing and complex memory. And crucially, it has Wernicke's area, which controls language comprehension.
Right, so Broca's is for speaking, Wernicke's is for understanding.
Precisely. So if a patient has receptive aphasia, they can talk, but it's just nonsense and they can't understand what you're saying. You're thinking damage to Wernicke's area in that temporal lobe.
And last but not least, the occipital lobe.
Straightforward but vital, the primary visual center. Damage there, even if the eyes themselves are perfectly fine, can cause blindness.
Okay, we can't forget the deep structures, the diencephalon.
Right. In there, you have the thalamus. Think of it as the major relay station, or like a central switchboard for the CNS. Almost all sensory info, except for smell, goes through the thalamus before it gets routed to the right lobe for processing.
And the hypothalamus, the master regulator.
Master regulator is the perfect term. It controls the autonomic nervous system temperature, fluid balance, endocrine function. A problem here can cause wild swings in vital signs or fluid balance, which can really impact mobility and cognition.
Okay, let's move down to the structure that is, arguably the most critical for just staying alive. The brainstem.
The non-negotiable life support system. It's made of the midbrain, the pons, and the medulla.
And it has the reticular activating system, the RAS, which controls awareness and alertness.
Right. The RAS is like a filter. So if you're asleep, a loud noise or a painful stimulus activates the RAS and it wakes you up. That process is fundamental to how we assess consciousness.
We have to know what the medulla and pons do specifically, right? Because a tiny lesion there can be catastrophic.
Immediately life-threatening. The medulla, for example, has the cardiac slowing center and the main respiratory center. Damage there, you'll see immediate changes in heart rate and breathing. It also has the nuclei for cranial nerves 9, X, and 12.
And the pons.
The pons also helps regulate. It has the cardiac acceleration centers and the pneumotaxic center, which fine-tunes your breathing pattern and rate. And it houses the nuclei for cranial nerves V, 6, SX, and 8.
So the key clinical insight here would be what, damage to the vagus nerve nucleus in the medulla could cause major swallowing problems?
Major swallowing problems, dysphagia, and even vocal cord paralysis. It shows how such a small area controls such huge life functions.
And right next door is the cerebellum, the coordinator.
The coordinator, exactly. It doesn't start movement, but it refines it. It's all about equilibrium, balance, and making sure your movements are smooth and skilled. If you keep missing when you reach for something, that's a cerebellar issue.
And here's that critical difference that always shows up on tests.
Yeah.
The motor cortex control is contralateral, opposite side, but cerebellar control is ipsilateral, same side.
Yes. So if a patient has trouble coordinating their right arm and leg, the problem is in the right side of their cerebellum.
Okay, let's talk about blood supply. The brain needs a ton of it all the time.
A huge metabolic demand. It's supplied by the carotid and vertebral arteries.
And those branch off and form the circle of Willis at the base of the brain. It's like a safety backup, right?
It can be. In theory, if one artery is partly blocked, the circle can sometimes provide collateral flow. But in reality, an interruption is devastating.
Especially in the middle cerebral artery, the MCA. That's the most common one for a stroke, isn't it?
It is. It supplies a massive area for motor and sensory function for hearing, An MCA stroke often gives you that classic one-sided weakness and aphasia. It hits both mobility and cognition hard.
Okay, last piece of anatomy, circling back to what you said about astrocytes. The blood-brain barrier, the BBB.
Right. The BBB is the ultimate gatekeeper. It's formed by these super tight junctions of capillary cells. It lets in the essentials, oxygen, glucose, water, but it keeps out harmful things like toxins and bacteria.
But it's a double-edged sword. It also keeps out a lot of medications we'd like to get in there.
It makes drug delivery a huge challenge. And here's the major clinical point for nurses. In times of neurologic disease, trauma, tumors, severe infection, that barrier is often not intact.
Which means the brain is suddenly vulnerable.
Extremely vulnerable. It drastically increases the risk for things like meningitis or encephalitis. It demands absolute vigilance with sterile technique.
Yeah, that sets the stage perfectly. So we've built the foundation. Now, let's jump into how we spot trouble in the real world. Section 2, the acute neurologic assessment. This is where it gets real.
And the single most critical piece of data you will collect is the level of consciousness, or LOC. It's the degree of alertness and how much stimulation you need to get the patient's attention. Any change here is a 5-alarm fire.
And we have to be really clear about the different states of awareness. An alert patient is awake and responsive. A lethargic patient is drowsy, but you can wake them up easily.
Then you have a stuporous patient. They require vigorous or painful stimulation like a sternal rub to get even a brief response.
And finally, comatose. Unconscious, cannot be aroused at all.
Right.
In an emergency, we often use the quick and dirty AVPU method. Alert, voice responsive, pain responsive, or unresponsive.
And that brings us to the #1 rule in neuronursing. A decrease in LOC or orientation is the earliest and most reliable indication that central neurologic function is declining.
You don't wait.
You do not wait. This is an immediate call to the rapid response team or the provider. This is the definition of a critical rescue priority.
So for a patient who is alert, we test orientation. We're shooting for alert and oriented ×4. Person, place, time, and situation.
And you have to ask specific questions, not just, do you know where you are? But what's the name of this hospital? What year is it? Why did you come in today?
To standardize all of this, we use the Glasgow Coma Scale, or GCS.
Yes. It gives us a reliable baseline so we can track those tiny changes. Highest score is 15, fully conscious. A score of 7 or less, that patient is comatose.
Let's break down the scoring because you have to be precise. It's 3 areas: eye-opening, motor response, and verbal response.
Eye-opening is max score of 4. It's just about opening the eyes. Spontaneous is a 4, to sound is 3, to pain is 2, never is 1, simple.
Verbal response, max score of 5. This tests cognition. Oriented is 5, confused is 4, inappropriate words is 3, just sounds is 2, and none is 1.
And then the most important part, the motor response, which has a max score of 6. This is where we see the most severe brain damage.
So a 6 is obeys commands. A 5 is localizes pain. They actually try to push you away.
Right. A 4 is normal flexion, just withdrawing from the pain. And then we get to the bad ones. 3 is abnormal flexion, which is decortication.
And a 2 is extension to cerebration. A 1 is no response at all.
The difference between decortication and decerebration is absolutely essential. Decortication, the score of 3, is abnormal flexion. The arms are pulled in toward the core of the body. Legs are extended.
It's a bad sign, but the brain is still sort of responding.
It's responding abnormally. But decerebration, the score of 2, is much, much worse. It means you have brainstem dysfunction. The arms and legs are rigidly extended, and you often see this arching of the back called opisotnos.
So going from a 3 to a 2 is a catastrophic change.
It's the difference between damage above the brainstem and damage in the brainstem. It's a massive deal. And numerically, a drop of 2 or more points in the total GCS score is clinically significant. You have to report that immediately.
Okay. Beyond consciousness, we have to look at vital signs.
Yeah.
They're regulated by the brainstem, so we look for that classic sign of increasing intracranial pressure, or ICP, the Cushing reflex, or triad.
The triad, yes. It's bradycardia, a slow heart rate. Hypertension with a widened pulse pressure, meaning the systolic is climbing, but the diastolic isn't.
And irregular respirations.
That's the triad. It's a late sign, but it's a devastating one. It means herniation is likely coming.
And for motor response in our alert patients, we're just comparing left to right, hand strength, squeeze, things like that.
Exactly. And you observe their movement and gait. Just watching a patient walk tells you so much. If they're unsteady, if they're listing to one side, you're thinking cerebellar dysfunction.
We also have to watch for involuntary movements, right? Tremors.
Yes. And the type of tremor helps you localize the problem. So that classic pill-rolling tremor that happens at rest, That's Parkinson's.
But an intention tremor is different. It only shows up when the patient tries to do something purposeful.
Right. And that often points more toward multiple sclerosis or other cerebellar problems.
Okay, that gives us the crisis toolkit.
Yeah.
Let's move to section 3. Cranial nerves, sensory perception, and some specific neuropathologies. The cranial nerves are the direct lines out of the brainstem, so they tell you exactly where the damage is.
There are 12 pairs, and assessing them is non-negotiable for monitoring brainstem function. For nurses, we really focus on the key functional groups: the eyes, the face, and the swallow.
Let's start with the eyes. The most acute check is the pupils, right? Controlled by cranial nerve third. We're checking parallel A. Pupils, equal, round, reactive to light and accommodation.
And you have to be precise. Use a millimeter scale. Unequal pupils, or pupils that become either pinpoint or blown and non-reactive. Those are immediate critical signs of neurologic decline. It means there's pressure on the midbrain.
And we check extraocular movements too, right? Making them follow your finger. That's testing nerves third, fourth, and sixth.
Yep. Then we check facial symmetry, CNE7, and so important, swallowing, CNE-SNX. For any patient with a decreased LSC, you have to check their gag reflex. If it's absent, they're at a huge risk for aspiration.
Let's use 2 PNS conditions to link this up. First, Bell's palsy.
Bell's palsy is a peripheral nerve disorder. It causes a one-sided paralysis of all the facial muscles because it affects the facial nerve CNE7.
The key finding is they can't close their eye on that side, right?
They cannot close the eye. The face just sags. So the #1 nursing safety priority for Bell's palsy is protecting that eye from drying out and getting injured. Artificial tears, patching, eye care is everything.
Okay, second one, trigeminal neuralgia.
This is a disorder of the trigeminal nerve, CNV. It's not paralysis, it's severe, debilitating pain along the nerve pathways. It can be triggered by just chewing or brushing teeth, or even a breeze on the face.
Wow.
The pain can be so bad that patients avoid eating or speaking.
So beyond the cranial nerves, we also have to assess the whole peripheral sensory system. Pain, temperature, touch.
Yeah, and a key test is light touch discrimination. You touch the patient in different spots and ask them to tell you where. You have to compare left to right all the way down.
And this helps you figure out if the problem is central, like a stroke, or peripheral, like diabetic neuropathy.
Exactly. Which leads us to one of the most dangerous PNS conditions you have to recognize: Guillain-Barré syndrome, or GBS.
Okay, GBS. This is a rare, acute inflammatory disorder that attacks the PNS. And it has a very specific pattern, doesn't it?
It does. It causes ascending muscle weakness or paralysis. It's thought to be autoimmune, and it often follows a mild respiratory or intestinal infection.
And when you say ascending, you mean it starts in the feet and moves up?
Starts in the lower extremities and moves up bilaterally, symmetrically. So you get weakness, numbness, and it progresses to paralysis. It can happen really fast.
And the immediate danger is that it's going to ascend to the diaphragm and intercostal muscles.
That's the life threat. It causes acute problems with breathing, talking, and swallowing. It hits all 3 of our pillars: mobility, sensory, and cognition if they become hypoxic.
So the nursing alert for GBS,
Yeah.
this is a big one.
Huge. The patient needs continuous neurologic assessment at least every hour because respiratory failure is a very real, very rapid possibility. You have to be watching their breathing like a hawk.
That's a great transition to section 4, diagnostic tests and our role in them. Here, the focus is really all about procedure safety.
It is. Starting with non-invasive imaging, you've got your basic x-rays, which look for fractures. Clinically, in any trauma, a C-spine x-ray has to be cleared first before you move the patient.
Then the CT scan. It's fast, painless, and it's the first choice for acute trauma, especially to rule out a bleed.
Right, and you can do a contrast-enhanced CT, which uses dye to light up tumors or abscesses. And that brings us to the issue of contrast safety.
But for better detail of soft tissue, we use an MRI. The big advantage is no radiation, right?
No radiation, just powerful magnetic field. It gives you incredible pictures of the brain and spinal cord. But the nursing role here is absolute safety screening.
Because of the magnet.
A powerful magnet. It is an absolute contraindication for anyone with a pacemaker, certain older implantable pumps, and especially any metal fragments in their body, like shrapnel. If there's any doubt, they cannot go in the scanner.
We also have MEG, magnetoencephalography, which is more advanced. The key takeaway is just that it's more accurate than a standard EEG at localizing brain function.
Right. Now for the invasive stuff. A lumbar puncture or spinal tap to analyze CSF.
This is where we insert a needle into the subarachnoid space in the low back to get a fluid sample.
And the nurse's job is all about patient positioning and safety. The patient has to be in a fetal side-lying position to open up those vertebrae.
And the #1 safety priority during the procedure.
The patient must not move. A slight twitch can cause nerve damage. If they're restless or confused, you need to get help to hold them still or consider sedation.
And we can't do it if they have a skin infection at the site or if they have signs of really high ICP.
Absolutely not. Removing fluid in that case could cause the brain to herniate.
Okay, post-procedure care. We're watching for complications.
Yeah.
The most common one is the post-LP headache.
Right. This is from CSF leaking out at the puncture site. It's a throbbing headache that gets way worse when the patient sits up and gets better when they lie flat.
So what's the nursing management for that?
Monitor them closely, encourage fluids to help replenish the CSF, and keep them on bed rest, lying flat, for whatever time your protocol says. This helps the whole seal up.
Okay, last one. Cerebral angiography. This is the gold standard for looking at the brain's blood vessels.
It is. We thread a catheter up from the femoral artery and inject contrast dye. The patient will feel a warm or hot sensation when the dye goes in. That's normal.
The #1 nursing safety priority here has to be the kidneys, right? Contrast nephrotoxicity.
100%. Patients with pre-existing kidney disease, diabetes, heart failure, they are at the highest risk.
So we have to do a lot of prep.
A ton of prep. You have to check their baseline creatinine and GFR. If they're borderline, we need to hydrate them aggressively with IV fluids before and after the procedure to help flush the dye out.
And we have to hold certain meds.
Yes. Kidney toxic drugs like metformin and NSAIDs have to be held for 24 to 40 hours before and after to protect the kidneys.
And after the procedure, the focus shifts to the insertion site, the femoral artery.
Right. You're monitoring for bleeding and swelling. Pressure dressing. Keep the leg straight and still for several hours.
And if it starts bleeding?
Immediate action. You apply firm manual pressure directly to the site, call for help, and start monitoring their blood pressure and pulse for any sign of shock. And you have to check the pulses in their foot to make sure circulation is still good.
Okay. Our final section. This brings it all together. How age and psychosocial factors influence everything we've talked about.
Right, connecting the physiology back to the patient. So with neurologic changes associated with aging, it is true that things slow down a bit. Older adults might have some recent memory loss, altered balance, decreased sensation, all increasing the risk for falls.
And their senses change, too. Pupils get smaller. They don't adapt to light as quickly.
And touch sensation decreases, which puts them at a huge risk for burns. They just don't feel that hot water or heating pad as quickly.
But here's the critical distinction, the one every student needs to know cold. Acute confusion or delirium is not a normal part of aging.
It is not. It almost always signals an acute illness, an infection like a UTI, hypoxia, low blood sugar, a drug reaction. Something is wrong.
So you never, ever dismiss it as just old age. You assess and manage it immediately.
Always. And when you're providing care, you have to adapt. Give them more time to process, provide written instructions, and just watch for those really subtle mental status changes that might be the first sign of a new illness.
And finally, we have to consider psychosocial factors and health equity. A neurologic event like a stroke is a life-altering catastrophe.
It is, and patients' responses are so individual, so influenced by their culture and their beliefs, we can't make assumptions.
And we also have to acknowledge that physical disability is more common in older adults from certain marginalized groups.
Yeah.
It connects directly to the social determinants of health.
It does. As a nurse, you have to assess those external factors. Do they have safe housing? Access to healthy food? Can they get to their follow-up appointments? These things have a massive impact on their recovery.
And tying it all the way back to the cellular level, we have to assess their nutrition history.
The brain needs a constant supply of glucose, and specifically, we need to ask about vitamin B12, which you get from eggs, beef, fish. A B12 deficiency can cause peripheral neuropathy and cognitive problems, hitting our sensory perception pillar hard.
Wow. Okay, so we've done it. We've covered the whole spectrum, from the myelin sheath to a GCS of 6 to the safety protocols for these major tests.
We have.
Let's summarize the absolute crucial takeaways, the things you have to know for your exams and your practice.
Okay. First, master the cerebral lobes and link every deficit to mobility, cognition, or sensory perception. Know the Glasgow Coma Scale cold, especially the difference between decortication and decerebration.
And never, ever forget that a sudden drop in LOC is the earliest and most reliable sign of neurologic decline. It demands immediate action.
And finally, prioritize safety during procedures. Know how to position for an LP and what to watch for afterward. and understand the entire protocol for preventing contrast nephrotoxicity during an angiogram, checking the GFR, pushing fluids, and holding those kidney toxic drugs.
This really just underscores how important meticulous hour-by-hour observation is in neurocare.
It's everything. And as you move forward, here's a final thought to chew on. Given that the blood-brain barrier is designed to protect the brain, but it's often compromised during neurologic illness, what unique challenges does this dual reality pose for developing future neuro-focused drugs? Drugs that have to somehow get through the barrier, but also help restore its protective function.